we're going to be looking at something very, very critical, which is our health sector. So over the next 90 minutes, we're having a conversation around what the Nigerian health economic outlook is like for 2022. It's coming at a very good time. We know how traumatized the sector has been, and we know what a lot of us have gone through in the last 2 years with the pandemic and with other things coming up. So there's no better time than now to discuss, what is in store for those of us in the health space. And to do justice to this conversation, we have Fisayo Okunsoya, who is extremely passionate about the healthcare sector. He's a strategist, but he's had a lot of interactions with healthcare practitioners, preferring solutions to them, helping them to clarify some of their thoughts, some of their positions. And I'm very sure that we're going to enjoy not only the presentation, but also the conversation that's going to be going on. So it's my pleasure to welcome you to our first health economic outlook. And I pray that you do enjoy, and not only do we enjoy, that we take some of the tips and we run with it. So I'm going to hand over now to Fisayo. Fisayo. Fisayo, can you hear me? Your mic is muted.
Good morning, Nika. How are you?
I'm fine.
Fantastic.
Awesome. So over to you.
Thank you. Thank you for the opportunity. First of all, let me take the opportunity to thank EDC and PharmAccess Group for this great opportunity to share some strategic direction or insight on the health sector, not just in 2022, but a bit of what has happened and a bit of where we are going. It's always a pleasure to share, and I will go straight into what we are about to talk about today. But before I start, let me just crave your indulgence that we have one ground rule that our mics are on mute, so that we can sort of enjoy the session with everyone that's here. I have a couple of slides, but I'm just going to talk through what we expect. Now, I have an approach to which I will be dissecting or breaking down this presentation. The first one, which we normally see the healthcare sector. So I'm going to be talking about the health sector in these ramifications. The first is the demand side. Those of us here that are in the health sector, that are in public health, we understand this fully. So the first is the demand side. Demand side, when we say demand side, we're talking about those that pay for healthcare. So everything that goes into health financing to pay for healthcare services. The second one, we'll be looking at the supply side, which consists of those that provide healthcare services. So typically that's where your hospitals and all your pharmacies, all the providers of some kind of healthcare services fall. And then I will also be looking at this at a macro level. And anytime we talk about macro, we're talking about the study of aggregates or aggregate level information. It's important in studying the economics of healthcare or health economics to talk about macro. Sometimes business owners tend to ignore the macro and act as if they operate in a vacuum. And one of the things the value we want to bring here today is to be able to look at macro level occurrence, global macro level analysis, and how it affects us on a micro level, which is the company or hospital or clinic or practice level. So we'll be looking at the demand side, we'll be looking at the supply side, we'll be looking at the macro level analysis, and then we'll be looking at how it affects the micro level. I mean, considering the fact that we've all been living in this world, some of these things are not new, but I want to start from the concept of globalization itself and what it has done to the playing field. Now, one of the best books, and I like to read a lot, so every time I get the opportunity to share, I like to share recommendations. One of the best books you will read about globalization is something by Thomas Friedman called The World is Flat. And one of the reasons I brought this, and I'll explain, is that the concept of globalization itself is that there's a breaking down of barriers, right? There's a breaking down of barriers. There's a breaking down of barriers to information, barriers to the flow of money, barriers to capacity and capability. So the idea was before globalization, money had to be spent in the country it was made. Goods had to be used in the country they were made. It took a long time to get goods from one country to the other. The supply chain just wasn't worth it. So I had to make I had to use what I was making. But through the internet and technology, globalization has broken the barriers. The first thing is the barrier of knowledge, right? The barrier of capacity. And that barrier of capacity means that capacity can flow easily from one country, especially through the internet these days. I can study online and become an expert, right? We have people in prison in other countries who have degrees that they earned in prison. That's powerful. That's the effect of globalization. But it has another side. The flip side of it is that knowledge becomes easy to access and the money becomes fungible. So which means that as money will become fungible and easy to move, it creates some form of instability. And it's important for us to understand this because the global economy will continue to go through cycles. And as it goes through these cycles, as we move and we advance and the operational level of technology increases, the cycles will be shorter. Recession cycles will be shorter. Pandemic cycles will be shorter. Obviously, pandemic cycles will be shorter because now it's easier. I mean, it takes 6 hours to get from Europe to Nigeria. So I can carry whatever, or a person can carry whatever disease that would have taken 3 months to cross the Atlantic in 6 hours. So it's important for us to understand. So Friedman's idea was that because the world is flat, we can see the end of the world, one end of the world to the other. And what Friedman was trying to say was that no matter whatever business you are doing, you are playing on a global level. Whether you are playing on a local scale, is your business, but your playing ground is global. And I'll say that again so you understand. Now, whether your scale is global, which means the size and the scope of your activities, is up to you, but you are playing on a global playing field. And that, of course, we all see now is the global supply chain for even talent, right? So it means that someone can sit down in China and be coming up with an idea that will wreck your business in Lagos. It's nothing personal, it's just business, right? And we've seen it happen over and over and over and over again in the law of invasion and succession in business, right? So Friedman came up with that theory, and that theory holds some weight, even though in a few years later, someone called David Smith, another book that I enjoyed reading, came up with a counter theory which modified Friedman's theory a little. And he wrote his book and called it The World is Curved. And he said, no matter how flat the world is, no matter how much information we seem to have, there are still uncertainties that we cannot predict. And if you are an entrepreneur in this day and age, especially in Africa, in Nigeria, you must understand that these uncertainties means no one knows tomorrow. And it also means that the cycle of crises in the world is getting shorter and shorter and shorter. This means that you are no more how we say, someone just doing, making ends meet and meeting customers' needs. If you are running a business, you need to build resilience into that business, right? You need to build resilience. So Friedman was of the opinion that the world and the global economy, and I want you to listen to this, the global economy will benchmark production where it is cheapest. So this is the concept of comparative and competitive strategy. It will benchmark production where it is cheapest. And that's how we see how China has risen. Anywhere, what that means for healthcare is that any country can become the medical tourism hub of the world if they can get it right, and get it right in terms of quality and in terms of cost. because the global economy will benchmark production where it is cheapest. And so, as a result of that, the global economy is looking for ideas to fund. However, markets must be developed. And this is very important for Nigeria because we go in with a silo mentality, especially in healthcare. We have such a fragmented healthcare system. But until the market is formed, nobody is going to enjoy the full benefits of what can be enjoyed. So here we are, following from what I've just said, we had a pandemic for breakfast, and it seems like we're having war for lunch. Now, in a pre-globalization world, nobody would have cared what was happening in Wuhan for the pandemic. It would have taken them maybe a year to even get it anywhere. By the time that year had come, had wound down, the thing would be less effective. Nobody would have cared what was happening in Ukraine in a pre-globalization era. But now, we hear that it's causing fuel scarcity. You know, in Nigeria, it affects us. What am I saying? It affects us. Every single thing affects us. I'm sure we don't want to go into lockdown again. We know how that was for business. We know how that was for everything we do. So the global economy, if you look at the 10 years from 2020 to 2022, the first step is pandemic for breakfast, war for lunch. And we're wondering what's going to happen for brunch, or for dinner, or for supper. You know, it's quite interesting that we start to look at it now. Now, there's something called in health economics the Overton window. The Overton window is the range of policies politically acceptable to mainstream population at any point in time. So let's say politicians have a stand on groups like the Health Federation of Nigeria are trying to sell policy ideas to them, and they're saying, no, we can't do this. Let's take, for example, tax rebates for doctors, you know. But after the pandemic, the Overton window shifts, right? After such an event as a pandemic, the Overton window shifts. Why? Because it becomes clear to everybody that even if you have so much money, you can't get on a plane and go anywhere. You have to fix your own healthcare system. I'm talking a lot today about the system, the sector, because that's where we are. That's where we got stuck. Until we fix that system sector, your businesses can be fixed. You know, you cannot do better than the sector in which you operate. That's just a simple law. And so the Overton window frames the ranges of policies that policymakers are willing to accept. And it seems like now is the best time to innovate for healthcare. It seems like now is the best time. We have the largest, the window has expanded, and we are able to do much more because it became clear to everyone that if we don't fix our health system, no matter how much money you have, you will get hit, especially during the pandemic. It also became clear to us that a health system that you do not invest in over the space of 60 years is not going to perform a miracle during a pandemic. It's not. And once those things became clear to us, the Overton window for policy shifted. For Lagos State, you can see increase in allocation to health. You can hear the federal government talking about health. You can hear multinationals trying to build more hospitals. You can hear that there's a lot of activity in healthcare. And that's one thing that as a CEO of any healthcare business or any health development organization, you should keep at the back of your mind, because it changes the range of opportunities that are available to you, and it changes what you want to do. However, what should we be focusing on? So going forward, most stakeholders will focus on the healthcare space, but what should we be focusing on? I think that's the thrust of this presentation today. What should we be focusing on? I'm going to present some data. I'm going to present some occurrences that we all have witnessed within our environment. And I want us to take a critical look and see if we are going about it the right way, and if this is how and what we should be focusing on, and what will build the system that would eventually build businesses. Now, let's look at the fiscal space, Nigeria's fiscal position, by analyzing our 2020 performance as a country. I want us to take this one by one very carefully. Now, this is as at half year, verified numbers from Ministry of Finance. I'll take it from the graphs on the left, the green graphs on the left, so that we can do one by one. And I want to paint a clear picture that we can all appreciate. Total revenue that we projected was 3.31 trillion. Total revenue realized was 66.7% of that revenue. Now put that in one side of your mind. Only 2/3 of the revenue came in 2021. This is after the pandemic. Debt servicing, as at half year, total debt was 2.2 trillion. And I want you to start, sorry, total debt servicing. Debt servicing refers to how much you are paying to service your debt. Not how much you owe, we owe much more, but how much, in accounting, there's something called periodicity. And it means that the portion of your debt that is due within a certain period. So debt servicing is how much we paid in that same half year of the 3.3 trillion, right? So you start making subtractions in your head that debt servicing is 87.4%. That's what we call our debt service ratio. Now, if you make 100 naira, you use 87 kobo to pay your debt, then you now start asking questions. Now, total expenditure was 13.08 trillion, right? And this is, and then allocation to health, this is for the full year, sorry, this allocation to health, 3.1%. Now, I don't know if this is a function of our priorities or a function of what we believe, but the question is, why does the healthcare sector keep getting this low allocation to health? And my answer is very simple, because we have not been able to prove to policymakers that healthcare is a business. There are sectors like economic development that get up to 20–30% allocation that are very quietly funded because they are sectors that provide returns. As long as we continue to make this argument for healthcare as just, and I choose my words carefully, just a social venture, then policymakers will shy away from allocating it. We have to get to a place where we say that it is a business with a social slant, because we won't throw away that social slant. However, healthcare must be treated like a business. Once we see it, then we know that government has no business in business. Government can create templates, benchmarks, but has no business in business. Then you know that our entire system is not structured to make universal healthcare coverage possible. And I'm going to prove that further. So we have 3.1% allocation to healthcare, and you will see we allocate more to defense, like we're in a war. Now, total health expenditure is 6.7 trillion. That is half of our budget. Now, that tells you already that the money to prove that healthcare is a business is within the system. And I'll show this in a more detailed form shortly. 77.2% of this 6.7 trillion comes from out-of-pocket funding, which means people pay cash without any form of health insurance or shielding or credit, out-of-pocket funding. From the above, I think one thing I want to be clear here is that Nigeria is not in a fiscal position to cover the gaps in its healthcare system. Don't expect the government to shell out funding to cover those gaps. Nigeria is not in that fiscal position to cover the gaps. Now, I want you to look at the GDP. I want to build this case quietly and carefully. From 2014 to 2021, after the initial slump of our GDP to about 3.75 billion in 2017, it has been marginally growing, and you can say there's been some stability, right? Now, This is despite our weak revenue. Now, what does that tell you? It tells you that if our government revenue is weak and our GDP is remaining stable, then we have a vibrant economy. We're just not capturing what that vibrant economy is. I'll say that again. If our government revenue is weak and our GDP is stable, contrary to what we like to believe or what has been sold to us, that the government is the biggest spender, the government is not, the private sector is, especially in the informal sector. We have a vibrant economy, albeit driven by the private sector. And I'm taking this argument somewhere. Now, I want you to also pay attention to this. This is very key because I'm going to use this data to make some points later. This is called the tax to GDP ratio, right? Which is just essentially what portion of our GDP, how do we collect tax? Are we effective in collecting tax enough? Now, the average tax to GDP ratio for OECD countries, which are the developed countries in the world, is 34%. The average tax to GDP ratio for African countries is 16.5%. Nigeria's tax to GDP ratio is between 3 and 6%. They say 6%, but it doesn't just quite gel. So it's really between 3 and 6%. International evidence shows, and this is from the IMF, that in order to have significant, accelerated, continuous development, sustainable development, you need a tax to GDP ratio of at least 12.7%. So let's just even agree that Nigeria is halfway there. In reality, like I said, it's like a quarter, right? So, but since I'm presenting this data, I need to stick with what can be defended, but you know, so 12.75% is what you need. 6.3% is what you have. Now, what does all this data mean? Let's get to the interesting part. Now, this is a breakdown of some of those yellow and green barriers I got to you, and this is health expenditure. Total health expenditure is $14.1 billion. Now, I want you to keep this at a point in your mind, and I want you to look at we always say as healthcare practitioners that Nigerians spend $1.5 billion on medical tourism. But at home, we are spending $14.1 billion. And I'll leave you to make the conclusions yourself. We're spending $1.5 billion on medical tourism, but at home, we're spending $14.1 billion. There is value in the economy, right? The money is going down in the healthcare system, but where is it going? And these are the questions. Now, of that $14.1 billion, 77.9 is private expenditure, which is like 80%, right? So 80% of that 77.9 is private expenditure. Now, of that 77.9, 0.7 is paid by private voluntary health insurance. That's you and me and our HMO plans at the middle class, higher class, whatever, all our HMO plans, right? Now, 77.2 is paid by out of pocket, which is staggering, which means that 77.2, less maybe the 1% who are quite wealthy, are one health catastrophe away from financial ruin. Now, government expenditure as a total of health expenditure is 14%. So if you add 77.9 to 14%, you get 92 thereabouts, right? Then the 8% that's left is donor-based. So it adds up to 100. So, but you can see the breakdown of our health expenditure. What does this tell us? It tells us that majority of the spend is in the private sector, and what is spent within the economy is more than the 1.5 billion that we keep touting as medical tourism. That's one. Two, it tells you that a huge portion of this money is out of pocket, which means if you go to the last mile, people are spending money on healthcare. Now, I want to start breaking down all the information I've shared and using it to analyze the healthcare system that we currently have. The pillars of social health insurance, there are three major pillars of social health insurance, if I remember my health economics. The first pillar of social health insurance is employee-employer contribution, which means that social health insurance is designed for you, is optimal when you can optimize, or is best when you can optimize employee-employer contributions. So you make a contribution, your employer makes a contribution. That's how social health insurance is designed. Now, we have a 70 to 80% informal sector, which means that you're going to already have a problem with social health insurance in its traditional way, because there's no way to capture employee-employer contributions. Now, what that means is that we need to find innovative ways to relate with to reframe the informal sector if our social insurance plans are going to work. We need to find innovative ways to formalize the informal sector in our interactions with them. Till today, you still have many entrepreneurs who have a lot of money but no health insurance. There's just no system, just like people don't like to pay for insurance. There's no formal system of collecting or of getting them to have health insurance. Maybe one day one of them falls ill and then they say, oh, they become a disciple of health insurance because they spend so much money. But for now, in its current form, our social health insurance is designed for employee-employer contributions. So our informal sector makes that difficult to achieve. The second pillar of social health insurance is tax-based, government tax, right? Tax to GDP ratio of 3 to 6% is going to make it difficult for you to collect, for you to fund your pool. Now, in the NHS, which is one of the most advanced health insurance systems that we all tout, their tax to GDP ratio is 33 to 40%, depending on the year. And so it's easy for them, right, to fund the pools. But we have the 3 to 6%, so we have an informal sector that we are not even collecting enough tax from. The third major pillar is the availability of basic quality healthcare in public clinics, right? Which means that if you want people to pay for insurance, you have to show them that there's somewhere that if they fell ill, they could go to. But here we have about 30,000 PHCs, of which only 20% are functional. And this was according to the former health minister, Dr. Adewale. Now, it means from all this that the traditional approach that we are taking to health insurance may not be the answer. And I know this may be controversial, but this has to be said. It has to be said because from NHS to some of the state-led insurance, health insurance schemes, we still are struggling, right? It doesn't mean that health insurance is not the answer, but it just means the traditional approaches that we've been taking may not be the answer, right? So you have a large informal sector, you need to innovatively reframe the informal sector and your relationship with them to capture them in the insurance pools. Even if you can convince them to join the insurance pools, you need to ensure that you have available basic healthcare so that if they pay this year, they will pay next year. Now, if the product that is being sold, which is the healthcare system, is not up to scratch, then you are selling, and then it's tough. You make it tough for the health insurance schemes to sell an impossible product. Now, look at other models around the world like the NHS. The NHS literally has the yam and the knife, if you permit me, right? So they control the demand and they control the supply side. So they reimburse healthcare providers and they also pay, get people paid to them. That's something that maybe we should consider, that the dichotomy between the PHC system and the health insurance system may be a problem. Because in order for universal healthcare coverage to be achievable, the PHC or the supply side and demand side must see themselves as Siamese twins. They must see themselves as Siamese twins. Now, when we talk about supply side, I'm not talking about public health systems alone. Even private healthcare businesses and the demand side must be working in tandem, right? Until that happens, we are far from universal healthcare coverage. We are not going to really move towards it. Now, health financing is the critical bridge between the demand and the supply side, right? But in the middle of it, for Nigeria, for our peculiar problems, we must start looking at innovative domestic resource mobilization. We must start looking at innovative domestic resource mobilization. In order to achieve that equity, we must looking at single large pools rather than this fragmented nature, because like I said, if we don't develop the system, none of us is going to benefit. But the minute money enters into the demand side, the supply side benefits. If we don't develop a strong demand side, we are going to have challenges with the supply side. So until we have a properly funded demand side, the supply side cannot thrive. And we need to start looking at that. The private sector, proven from the numbers I've shown you, is one of the major domestic resource mobilization tools, right? Where the private sector needs to be fully engaged. And I'm going to get to that in terms of between the private, public-private themselves, because there's a lot of wastage right now between private themselves. Now, if we do a small analysis of the supply side, so that was demand side. If we do a little analysis of the supply side, right? In terms of infrastructure, we have large government hospitals that need renovation, right? We have fragmented private sector. You know, in spending time giving private businesses loans, consulting for private businesses, I come in contact with this even till date, and it's quite a bit frustrating. Everybody wants an MRI. Everybody wants a CT scan. And there's nothing wrong with all this. Everybody wants the biggest hospital. Everybody wants, you know, someone said doctors like toys. And I'm not saying that that's true or false, but everybody wants this MRI. So I sat with one doctor one day and I said, an MRI is $1 million, right? How much do you think you need to break even if you buy an MRI? How much do you think you need to break even in 4 years? You need at least 15 to 17 scans a day at 60 to 75,000 naira. The fiscal space may not support it depending on where you locate your MRI. There are strategies to locate it, but depending on where you locate it, it may not support it. Why do you want an MRI? Okay, how many scans are you referring out in a day? And the guy says 2. If you are referring out 2 scans a day, some days 1.5, why don't you partner with someone and strengthen the supply side rather than having several MRIs and a lot of debt? Now, what happens now? There's now excess capacity within the system, right? That is unutilized. You have large hospitals that bed occupancy is 30%. You know, I personally do not believe that Nigeria's fiscal space at the moment, I mean, can support all these large 200, 300, 150 beds. Oh, it can't, right? And you know, again, it might be controversial. We quote India, but India has over 1 billion people. India has 300 million millionaires, which means 300 million Indians are millionaires. Their healthcare system can have 500 beds. So when we say, oh, India has 500 beds, we need to come back and look at what Nigeria's fiscal space is. Because as someone who spends his days looking at the books of hospitals, it will take a long time to break even. We need to revise this mindset. It will take a long time. Some hospitals have not broken even in 10 years because we went into it without the understanding of the business. Now, if you look at equipment, sophisticated equipment in a lot of private hospitals, private centers don't work. Public centers also don't work, right? Equipment in private centers largely underutilized, like I said, excess capacity, wastage. And this is why capitation will never be enough. And I said to someone, I said, when I pay capitation for you, I'm paying for your consulting room. And I want this to be clear, health insurance. When I pay capitation, I'm paying for your consulting room. Your 200 kVA generator is not really my business as a health insurance scheme. You have overloaded your cost basis. I'm paying, which is why you must give kudos to PharmAccess, for instance. When PharmAccess was rolling out the access to finance, that's the only solution that can cut the cost of providing care, that can make whatever we have to pay for capitation enough, a lean benefit package and functional, not necessarily overly built hospitals, but functional healthcare centers that have safe care methodology, that give functional care and can provide basic quality care. Because 50% of our disease burden is malaria and typhoid anyway. And we need to start being real with this conversation, right? 30,000 PHCs, abandoned PHCs all over the country, and we still want to build more. Massive hospitals having 30%, 20% bed capacity, and we still want to build more. Now, there's nothing wrong with building more, but the fiscal space must follow. The demand side, and I'll show you a case study, the demand side must follow the supply side. Now, the third issue on the supply side is people. Of course, we see this massive exodus of health workers, again, which is why I started with globalization, in response to a global war for talent. Yet other cadres are ignored, right? One day we need to wake up and say like TBAs and PPMVs are the first line of care in Nigeria. One day, we need to have that conversation and say PPMVs, which is patent medicine vendors and traditional birth attendants, are the first line of care in Nigeria. I can tell you authoritatively from some of the data we have, which is purely proprietary that we can't share, is that maybe about 20% of the women who come for antenatal come to the public or private centers to give birth. The TBAs are doing a lot of work. That's where a lot of the money in the informal sector that you see in healthcare expenditure is going. But we cannot keep excluding them from the healthcare system. There are local governments in this country that have no community pharmacists, which we call CPs, but PPMVs are there. And some of these PPMVs go to large extent doing unethical things, because anything that you do not, when you employ protectionism and you ban things, you feed them to grow, right? So we need to open the doors and say, how do we, through task shifting, task sharing, tackle our brain drain and find ways for these guys to be part of the health system, recognized so that they can be properly regulated. Now, I want to do a case study of Nollywood. I thought this would be interesting to drive home the point that I'm making about the economics of healthcare in Nigeria and what we need to do to go forward. Prior to 2015, we had a large number of low-quality movies. I mean, it used to baffle me how some of the very intelligent and talented actors would act some of these movies. You see R&D in one funny movie, and just what's happening here? And because at the time, I probably didn't understand health systems and how economic systems work. That until you sort out distribution and the last mile and feed the actor, the quality will not increase. It's the same thing for healthcare. But I'll stress it later. The market was controlled by Alaba boys who owned the distribution network. So and this was the same for the music market. Those guys would determine what they feel will sell. And they will go and tell the producers what they think they should make. Don't do anything fancy. This is what you need to do. We want to push it out. And that's how the market was working. Actors were paid poorly, and this affected the quality of movies. So the idea was, if I was earning 200,000 naira for a movie and I was a big-time actor, let me make 5 in a month, rather than sit down and make 1 in 3 months and earn well. Let me make 5 in a month. So it was really about churning it out. Now, from 2015, 2016, streaming services came and cinemas became popular. So if I release a movie now, it comes out in the cinemas, and the streaming services like Netflix, Iroko TV, release that movie. And it cut off the Alaba boys immediately. And that's what we need to do in healthcare. We talk about the open market for pharmacies. We need to leave the open market, don't address them. Look for innovative ways to cut off that open market that's increasing the price of drugs, that's also proliferating fake drugs, right? It cut off the Alaba boys and immediately was providing the actors with money directly, the producers with money directly. Immediately, actors started getting paid more from 2015. The kind of people who wanted to go into acting changed. As a follow-up, brands, because these Nigerians now started appreciating those movies, thank God for DSTV, And the brand started now using them as ambassadors. So even beyond what you get paid for a movie, you could get endorsements. I mean, actors are now getting endorsements in land, in houses, so they could live comfortably, right? In cars, and they're doing well. Digital distribution gave movie makers direct access to the last mile, and that is it. How do you ensure that the money, the 14.1, and this is the question I'm asking, how do we ensure that the 14.1 billion in healthcare expenditure gets to the hands of the doctors and the hospital administrators and the owners of the infrastructure and equipment? Of course, the quality of movies increased. You found actors now going to New York Film Academy because they found that there could be dividend for their trade. In fact, some fellow brought New York Film Academy to train people, and I can remember they charged $5,000 a pop, and people paid for like 3 months. The kind of cameras and equipment increased, and the scripts started to make a bit more sense, right? You saw Tinsel, and you saw some movies started to make a bit more sense. I'm not saying they're the best now, but it started to make a bit more sense. Now, what this means, essentially, what this means is the approach was not to just start buying equipment without sorting out the distribution end. You need to sort out the distribution end of things for any sector. So now Nollywood is worth between 1.1 billion and 3 billion per annum, 2.5 million movies annually. I mean, you can imagine 2.5 million movies annually, right? So I did a list of all the movies that have done well in the last few years. And you can imagine one movie grossing about 636 million. So the industry has therefore seriously changed because they fixed the last mile, right? And I want you to use that as health sector, right? How did we fix how can we fix the last mile so that the money that goes into the system gets into the hands of the supply side? How can we have innovative financing models so that the money that goes into the demand side gets into the hand of the supply side? This is the question, and that is the answer, right? Okay, so I mean, this is how Nollywood sort of developed. Now, I have another case study of Thailand. Very interesting how Thailand achieved universal health coverage, right? Now, I'll follow these steps. I'll see what Thailand did. One, they invested in health infrastructure with innovative public and private partnerships. So the government came together and said, as a government, I'm not going to go around building. No, I'm just going to build models of what I want our hospitals to look like, benchmark centers of excellence of what I want those hospitals to look like, right? Then two, they set up a mandatory health insurance scheme and they enforced it, which is, we have mandatory health insurance schemes that are not enforceable yet. Hopefully, as we're able to enforce them and rewrite some of those laws, we'll get better coverage. Then they converted, look at this, after they got the private sector in, set up mandatory health insurance, then they converted the entire government budget to demand side, i.e. pay for services. So the government said, I'm not going to buy any equipment anymore. I'm not going to build any, after I've shown you with my benchmark centers, I'm going to now pay for services. Once they did that, they now increased the allocation for health. Now, which means that increasing the allocation for health is not solely the answer. Because if you throw money at that infrastructure, we have infrastructure sitting in places all over the country that's not functioning. I mean, in the work we have done inspecting facilities, we have ambulances sitting that have not been driven for 1 day in 10 years. We have generators sitting in hospitals in the village that were donated. Nothing. It's not about that. It's about having a model that works properly that you can now then scale up. So after they transfer their entire healthcare budget to demand side, they now increase the allocation and they achieve universal healthcare coverage. What are we saying? We're saying that rather than build more infrastructure, and this is also to large multinationals that still want to keep donating, no, pay for services and the private sector will take over itself. If the private sector knows that once I get into this thing, I will get paid, trust me, they will come in and the invisible hand that Adam Smith described in The Wealth of Nations. The invisible hand will take over. So as I wrap up, let me make some very clear statements about the future of the healthcare sector in Nigeria. The first is that payment for service, as opposed to building more infrastructure and buying equipment, needs to be the way forward. Stimulating participation in the industry. Private sector providers will come and take their place if there is reward at the end of the day. If there is reward at the end of the day, they will come and take their place. Now, for healthcare practitioners, each practitioner must find a way to invest in the business of healthcare. I remember we had something after the health management program where we went to Kenya, and we sat with one of these young doctors who owned the hospital, and he was the first person who said that, and it started to make sense to me, that you cannot invest in the clinical and you cannot focus on the clinical part of healthcare and the business at the same time. One will suffer. Initially, I was opposed to this idea until he explained it, and then a few years later, I started to see it. Focus on the clinical aspect alone of healthcare, your business will suffer, and we've seen that. And if you focus on the business aspect alone for healthcare, you will not be cutting edge as you should be. Very interesting. So we need to invest, and this is why the PharmAccess and EDC set up the HMP. And I want to take a minute to talk about that and say that if you haven't attended the HMP, ask people about it. I think there are enough students that have graduated that program to be able to tell you now that apart from the network of business minds that you meet, there's also a very strong affiliation. There's also a very strong capacity building on the business of healthcare, you know? So sometimes when I write business plans for hospitals, people come to me and say, I want to do this part of hospital, this specialty. And I always tell them, I say, when you enter a hospital, there are money makers and they are bleeders. If you want to set up a hospital business that has solely bleeders and you don't want to do the money makers, then you're already setting yourself for failure in the beginning, right? So you have bleeders, you have money makers, you balance your business model to ensure that your bleeders do not overtake the money makers, right? So if you have this massive 100-bed and there are only 10 people in the hospital, your 200 kVA generator still needs to be on. Then your inpatient becomes a bleeder. You know, so it's important that we understand all the aspects of business, supply chain for healthcare, hospital financial management. You know, I always say that given the direction of the global economy now, in the past, as a doctor, you could be the accountant. But if you try it today, you'll be a scattered accountant, right? Now, you cannot just recruit an accountant, and you can ask those who run big hospitals here. You can't recruit an accountant anymore. Your accountant needs more competency because the global economy is now complex. You need not just an accountant, you need a treasurer in your hospital now. This was competence that was reserved for banks before. You now need a treasurer. Why? Because you now need a finance system that's not just reporting what happened. You need a finance system that is telling you where to place a position, that's telling you how to position your balance sheet. Why? Because we are all susceptible to risk. Let's take foreign exchange risk, for instance. You want to buy an MRI in December, but the dollar is now 570. Even if you get it at CBN rates for 419 or 415, do you know what the dollar will be in December? So you don't have the money now. What do? There are many things you can do. A treasurer knows forward contracts. A treasurer knows so many things, right? You may be sitting there and saying, oh, we'll buy it when we have the money. But if you had an accounting team that was sharp, they'll be able to use hedging instruments to save you anything between 50 and 100 million naira on just that machine that you want to buy. So your accounting system needs to be more for your hospital that is serious-minded, needs to be evolved. So that's why we teach hospital financial management. You teach procurement, you know, LCs. Doctors must know what a letter of credit is. You are importing consumables, you are importing equipment. You must understand, at least at the very minimal, you must have a basic understanding of business generally, strategy. How do you put together a business plan? How do you raise money? I mean, the economics of running a hospital. Who do you take money from? I mean, we've seen a lot happen over the last few years in hospital businesses that have not gone too well, especially with funders, and sometimes I sit down and I say, these are fundamental mistakes. Now I'm talking on the micro level now. I've gone from macro to micro, from demand to supply. On the micro level, they're fundamental mistakes. So while I still have time, let me just mention one or two things that you must never do with finance. One, private equity is not for healthcare. Again, this might sound controversial, but I have experience in this. If you're going to take private equity, take impact private equity. There's a difference. An impact fund has some element of subsidization in it, right? And that impact fund knows that it is long-term capital, right? That is going to wait for you. When we try and do returns on normal businesses, we use a 5-year stream for normal businesses. But I always stress to all the investment world that we must use a 7-year for healthcare, right? We must use a 7-year for healthcare. So I've been asked to pause a bit to take questions, but I'm almost done actually. So can I just wrap up? I have 2 slides left. Let me wrap up and I'll take those questions. So you must use a 7-year. Why? Because your healthcare equipment are they're expensive, and they are treated as specialized equipment. Because they are expensive and treated as specialized equipment, it will take longer for those equipment to break even. So private equity that's looking to exit in 3 years is not going to be yours. Now, when you sign those contracts with the private equity people and say in 3 years it is convertible, and you sign what they call a convertible loan or a convertible, what you're saying is that if I can't pay, it should turn to equity. And that's why eventually what happens is that they take your business from you. And we don't want that to happen. The second one I'll say, and then I move on, is that you must try not to bear the foreign exchange risk of any transaction you are doing, especially if you are operating in Nigeria. Try not to take foreign loans. They might be cheaper in that they can do 9%, 8%, or even 7%. But when you have to pay back in dollars, then you're going to have challenges in this economy. Sometimes it's just the scarcity of the dollars, especially because you earn in Naira. Except you earn in Naira. If you don't earn in Naira, don't bear foreign exchange risk, right? We found a lot of people who took loans that they thought were attractive, only to end up losing so much money because the Naira just shifted by 100 Naira. I mean, a few years ago, it was 145, 360, now it's 5 something. Imagine someone that took a 10-year loan, which like healthcare people like to talk about, at 145. You will still be paying interest, and you will not have scratched the principal, and you feel like you're working for others. Now, one of the other things of healthcare in the future, and I think Nigerian healthcare providers need to get into, is that data protection is going to be a big theme in the healthcare sector, right? And data protection and data services is going to be a big theme, right? Patients will be very mobile. We're already seeing technology platforms that are providing patients with their own data in their hands. What it means is that when you go to the doctor, you have an app that has all your data and you can port easily, right? And I think finally, I want to talk about collaborations. Collaborations must be the order of the day, right? Provider payment mechanisms will enforce efficiency. And I'm talking about like health insurance. Health insurance will enforce efficiency. Just through the capitation system, it will force you to be bare minimum, which means all the excess capacity that is in your hospital, you can't afford it. You cannot afford to have assets that you are not sweating. You cannot afford to have assets that you are not sweating. So consider co-location of specialties. We're going to start seeing health malls where people just come and have a consulting room and can share a theater, share an MRI. We are going to, that trust must be established between practitioners. If the industry is going to grow, we are going to start seeing a lot of co-location. People are going to start asking themselves, especially diaspora doctors who return. They've seen the model outside. They're going to start asking themselves, why do I need to build this massive hospital, right? I mean, doctors abroad, most of them just have this small practice, and then they have rights to operate in several clinics. This is efficiency, and that's why those health systems are very great, right? So it's very important. Collaborations must be the order of the day. In conclusion, what have we learned? Every business, including those in the healthcare space, are operating on a global playing field. And I said this, and I want to say it again. You are operating on a global playing field, which means there's someone sitting down in China coming up with innovations that will wreck your business in Lagos. It's nothing personal, it's just business. Second thing we learned is that the federal government and governments at all levels do not have the resources to fund the gaps in the healthcare sector. So they're going to lean on the private sector. The third thing we learned is that our current societal structure may not be able to support health insurance in its traditional form. So we need to start getting innovative. We need to start getting innovative. Until we develop a vibrant demand side, there's no point building massive hospital edifices. And I know, like I said, this may be controversial. They might not break even, you know, except you have some development funding that is sort of like a donation. Then you can have a model that works that way. Innovative approaches to domestic resource mobilization will be the saving grace for our health system. It has to come from us. The time to act is now. Just like Sir Winston Churchill said, never let a good crisis go to waste. COVID-19 has shown that we have to focus on the healthcare system, and I think that this is an opportunity like we've never had to focus on the healthcare system. Thank you very much for having me. I think there are a few questions. Chinedu, you want to help out? How do you want us to take these questions?
Yeah, okay, Fisayo, I think you can directly take the questions, or do you want me to read out the questions? I think it's easier if you can directly take the questions from the comment box.
Thank you. Okay, so Mr. Clark Azubuike says, thank you, Fisayo. This is a fantastic presentation. Some questions. I would like you to comment on the idea of value-based care and how you think it fits into the business of healthcare. Then it says, you have not alluded to disparities in healthcare access. The availability of infrastructure is not even across the country. There are more private hospitals in the south compared to the north, and more urban versus rural. How do we address this? Finally, what is the role of digital health in expanding healthcare services? Fantastic, thank you for that. Let me start from digital healthcare, because digital healthcare will probably start to answer some of the other questions. Telemedicine, let's start with telemedicine. Again, I've been privileged to do a lot of research in different states, disease burden research, right? Disease demand research. I found that same for the states we've worked in, that the large diseases, or the majority, 50% at the very least, are malaria and typhoid, which means that you don't need anything stronger than primary health, right? Now, private hospitals, again, so the answer to the question on digital healthcare is the future of healthcare is digital. Let me say that. PharmAccess has been saying that for years. Let me say it again. The future of healthcare is digital. Why? Because we have one of the hugest penetration of mobile technology. So even though regulation may be blocking the launching of mobile technology or mobile money, which would drive mobile health, policy will shift. Like I said, the Overton window has shifted. So the future of healthcare is digital, not just EMRs. I don't want to see it just as EMRs. I want to see it in terms of access to mobile technology, access to health insurance through, and financial inclusion. So as financial inclusion increases, that money in the informal sector becomes mopped up, and then you can capture more people in your healthcare system. Remember, I said that you have a large informal sector, but you have to look for ways to capture them and formalize them. Financial inclusion through health technology, through mobile money, is a way to formalize that and bring the informal sector into your fold. And so the future of healthcare is digital. So let me answer that question that way. Now, I don't want, and when you talk about disparities, I don't want you to see the only direction for growth as private. Remember I said private-public, right? Yes, there are more private hospitals in the south, but there are more public hospitals in the north. So Lagos, for instance, has 326 primary health care centers. There are some states, by the time you get to Kwara, you're looking at almost 700 primary health care centers. If you go to Adamawa, you're looking at some states have 1,000 primary health care centers in the north, right? And some of them are abandoned. A lot of them are abandoned. Must the private sector now build their own hospitals? Can the private sector run public healthcare centers? These are questions that I'm throwing back at you, you know, to address the question of disparity and in rural areas. I've been to many rural areas that have facilities that government built for many years, you know, and you know, the private sector is probably the only way to run these facilities, you know, and that idea of segmentation, of fragmentation, sorry, is what I don't want you to carry away from here, which is why I've alluded to the fact that, and I said it earlier when I said PharmAccess has said that you can do something, what they call the access to finance, and you can, private sector can run public sector hospitals, right? Now, thank you for your PowerPoint. What's your opinion about group practice as a model for hospital investment? Like I said, partnerships. I fully am on board with group practice, but I found in my practical experience that a lot of doctors don't trust each other, right? That trust, not seeing each other as competitors, but complementary businesses, is what is keeping us fragmented. If we bring the right, how will I say, specialties together, we can have beautiful group practices like they have elsewhere in the world. And you know, you have complementary practices. That is the future. So everybody does not need to have his own account, HR, generator, and all that. That brings efficiency. Anyway, in any case, if we don't do it, provider payment mechanisms will force that efficiency, right? So we're going to have to find a way to operate our healthcare facilities within the limited fiscal space that we have. Okay. Really great presentation. Could you share your thoughts on the ongoing tariff war between HMO and providers, where both sides feel that they are being cheated and prices are not fair? How can demand side positively incentivize the supply side? Will you say it's fee for service? Again, our system for provider payment mechanisms are very narrow. There's more to provider payment mechanisms than capitation and fee for service. I mean, there's more. You can use many more DRGs, right? You can use global payment. You know, there are so many, and we need to start looking at the possibility of going deeper, especially for having pools for specialized care. Now, in terms of the price war between HMOs and providers, there is a negotiation game, and someone is always going to feel cheated, right? But my advice will be to providers to say, become lean so that you can accommodate what the HMO is giving you. Now, in most other countries, the HMO pays a very small percentage of what your fees are, but they give you volume. And that's where the NHS doesn't quite work out, or some other HMOs. You don't have the volume required for those fees that they're asking. And that's why I'm talking about the market in the current form and saying the way we are doing it may not work, right? So even if I'm going to pay you 30% of what your fees are or 40% of what your fees are, am I able to keep you busy? That's the question. If your MRI is 65,000 naira and I tell you I'm paying 30,000 naira for your MRI, if I can give you 20 scans a day, then you know it's worth your while. And that's the idea. How do we balance that fees that the HMOs want to pay with volume? Again, I throw that question back to you because that's really what the case is. Someone says, thank you for the brilliant presentation. My question is, what will be the future application of business intelligence, analytics, and big data in healthcare logistics. Oh, wow. So this is somewhere that I'm very passionate about, big data in healthcare. Right now, we're flying without a clear understanding of our health system. That's the truth. We're just trying to assume what's happening because we don't have clear data, especially because of the fragmentation. We don't have central pools of data, right? Now, as the health system becomes more intelligent, which is happening now, and data becomes more aggregated, we become more targeted towards meeting the needs. I think that data is the new oil, and healthcare data is going to be one of the biggest. And that's what I feel. The future applications will be in managing diseases. The future applications will be in precision medicine. The future applications will be nipping endemics in the bud before they become pandemics. You know, the future application will be in localizing diseases, reducing maternal mortality. You know, when you have data, and I mean, this is something that was discovered in Delta State, that after women come for antenatal, they just go missing. And you just say maternal mortality is high, but they go missing. Where are they going? Oh, culture says that they must not be seen around the time of birth. You know, if you don't have data, you don't know those things. And once you have data, you can now address it, right? So the future of healthcare, of better health outcomes for Nigeria is data, right? Okay, thank you. Yes, I'm sure this will provide the slides. Someone said, can we have the slides? Thank you. Our current societal, okay, I said our current societal structure may not support health insurance in its traditional form. This is an excellent view. Can you please shed more light? I think I shed light on it, but let me say it, that I said the three major pillars of social health insurance, our system does not naturally meet the requirements of those pillars, which is one, tax, employer contributions, government tax, and up-to-date primary healthcare centers. And as long as our system does not meet that, if we deploy health insurance in its normal form without any innovation, we won't get any traction. What we need to do for the informal sector is to reframe it. What we need to do is find ways. Once we reframe the informal sector, we can collect more tax, and we need to get our PHCs running. Thank you, beautiful presentation. Following your case study example about setting up benchmark sector, do you think something similar could work in Nigeria? And so either PPPs or franchising arrangements are what providers such as labs, etc. What intentionally leans towards? Yes, I think it could work in Nigeria. It must work. Let me put it this way: it must work in Nigeria because the government does not have money to, even if they build and someone donates these hospitals. Do you know how much it is to staff 30,000 PHCs in a year? It doesn't make sense. I mean, when you do the numbers, it doesn't make sense. So it only makes sense for the government to unleash the private sector, right? And create the enabling environment, then unleash the private sector. And you find out that once the private sector has volume, they will not really complain. I mean, imagine if you say capitation is small, but you had 40,000 patients across 4 centers. I mean, start doing the numbers in your head. Yes, they might come en masse, but after a while, they found that no more than 20 or 30% of people will come. After they know that this health insurance scheme is not going anywhere, then they start reducing their attendance and you start to benefit. Thank you, great work. Okay. What is your opinion about budget private hospitals, especially those that don't want to become big hospitals and are just comfortable? Okay, so this is quite interesting because there are schools of thought here. There's a school of thought that believes that hospitals will struggle until they reach 100 beds. That's one school of thought. There's another school of thought that believes that the bigger they are, the harder they fall, especially in the market where the fiscal space does not support it. I think you can run a budget private hospital, but there's a break-even point that you must admit, and that may be in number of beds, or maybe in an outpatient capacity, number of patients that you see in a certain day. Again, you must think about the bleeders and the money makers. Remember that your OPD is largely a bleeder, right? And it means that it doesn't make money as much as your three major money makers, which are your lab, your radiology, and your pharmacy, right? So is the ability to balance those things that determines whether your budget hospital will be a money maker. For instance, I can have a small clinic beside a strong X-ray CT scan business, and the CT scan and the X-ray are doing 300, 400, 500 scans a month, and I'm able to use it to subsidize the clinic. So it depends on the business model. When I talk about demand side funding, where poverty is high and confidence of many lies mostly with quacks, how can we solve the problem? Policy, I think. Policy, yes. Because when you start talking about quacks and health-seeking behavior, I know a lot of NGOs are trying to do a lot about it, but there's a lot more. How can health insurance be provided to the informal sector, bearing in mind collection and organization? You have to reframe the informal sector. First of all, Nigeria's informal sector is quite organized, but we have not harnessed the organization of the informal sector. We have not really harnessed it. One of the things we learned in India, in studying India and Pakistan and some of those countries in their informal sector, we found out that the informal sector was part of the process of creating the health insurance scheme. And they are on the boards of the health insurance scheme, of the health insurance authority. I'll give you an example, like Modicare and all of them. Let me use Nigeria as an example. If you have NURTW, for instance, right? You don't create benefit packages or health insurance, whatever, without NURTW. And NURTW needs to be on the board of your health insurance agency. Why? Because that ownership, until that ownership exists, nothing happens, right? That's what they do in India and in some of the other countries, right? So when you say informal sector, remember I said you formalize the informal sector. There are cooperatives all over this country. There are taxi drivers associations. Those are formalizations within the informal sector that we need to sell to and include within our narrative of health insurance. And that's some of the innovation that I've been talking about. Certificate. Thank you again. Data protection has become big discussion. Yes. How does Data Protection Act, according to NDPR, influence healthcare? One of the major things that's happening now is GDPR and NDPR, which is Nigerian Data Protection Regulation and Global Data Protection Regulation. The NITDA is in charge of the NDPR, and they're going through hospitals now. And I think I should have mentioned this, but thank you for this question. Every hospital has to have a data champion in 2022. If you don't have, please take it from today that you need to appoint data champion in 2022. NITDA will come for you. Why? Because you are taking people's data and you need to be NITDA compliant, right? So in how you manage that data. There's a whole act that you need to read about and how you manage patient data, patient rights. The patient rights bill is also there coming up. Data is going to be very, very big. Okay, this is a long question from Ms. Ndili. Digital transformations are well underway in all areas. These have brought about substantial and wide-reaching changes in many areas, but large gaps remain in our understanding of the interface. It's a comment. Yes, okay.
Yeah, comment.
Yes, it's a comment. Thank you. Thank you so much. And it's very, 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 very true. Large gaps remain in our understanding of the interface between digital technologies and health, particularly for the young, right? So the Lancet Financial Times Commission on Governing Health Future 2030, growing up in a digital digital world, argues that digital transformation should be key consideration as a determinant of health. But the Commission also presses for a radical rethink of digital technologies, highlighting that without a precautionary, mission-oriented, value-based approach to its governance, digital transformation will fail to bring improved. Brilliant. Thank you so much, Matt. This is brilliant. And one of the reasons I say it's brilliant is that there needs to be a cost. Technology is not a solution in its own. I've always said this. Technology only automates your solution. So just like she said, if there is no clear governance or value-based approach, mission-oriented, this is what we want to achieve with digital technology. And we fall into a trap. We might fall into the trap because there's a lot of proliferation of digital technology now. And I always wonder about things like interoperability and whether they can all be harnessed to align to a certain mission-oriented, value-based approach. Thank you so much for that, Njide. How can we convince our politicians to invest in the demand side to achieve UHC? Yes, that's a question that I've been thinking also about, because it's easy to say I built a hospital for my constituency, right? Investing in the demand side is the future. And I'm right now dealing with stakeholders and I'm having difficulty convincing them. I guess advocacy, I guess bodies just need to keep talking about. First of all, we need them to stop seeing we healthcare people as not understanding economics or not understanding the economics of it. Once that perception is gone, then we will now be able to say that, oh, we understand economics, we understand the money, and we are here for business, right? I think that's it. Another question of the presentation. Since health insurance is a game of numbers and the numbers belong to who is, yeah, okay. Okay, someone said the money makers again. So traditionally your money makers are your laboratory. I say again, because you can commoditize the products and churn them out for a fee. Your radiology, which is where your scans and your imaging are, and your pharmacy. Some people are able to turn their inpatients to money makers, but that only happens when you have a critical mass of patients. It can be a good money maker. Your bleeders, laterally your OPD, after the patient comes for consulting, you pay repeat consulting. Again, your OPD is not going to make you a lot of money. Sometimes your ICU, because after the patient pays for the first week, and I know we collect 1 week in advance, what happens if the patient cannot pay for the other week? You don't want to be the person disconnecting the patient from the ventilator, you know, so the ICU needs to be watched carefully. How do we leverage big data in healthcare without violating privacy and ethical consent? Again, you need to go and read the NITDA and NDPR. But we can't leverage big data with big pharma, with big, you know, by anonymizing data itself. And there are rules about anonymizing data and telling stories about health systems on a macro level without actually giving out patient data, you know, to anybody in the name of big data. Following the economic outlook presented, it is obvious that funding needs to be channeled back to providers. Where should the advocacy be focused on? Do healthcare providers need to unite and provide a business case? And if so, which suggested advocacy group can handle this? Beautiful question from Mr. Osisiebu. Yes, advocacy should be focused on, one, government should get out of doing business. 2, government should provide the enabling environment, bring the patients, bring the payment mechanisms, who would provide the providers. Sweeteners to help us do business and crash our costs. So if we have problems, for instance, with power, but we don't have a problem with bulk power, then we should start thinking about bulk power arrangements for healthcare providers, right? We should start thinking about not just intervention funds. One of the reasons I don't like intervention funds, and they've not worked because they bypass the economy. How do we also create things that don't bypass the economy, especially on the financial and funding side, you know, that is sustainable? Policy is the instrument of government, and advocacy must be towards policy. I think that the Health Federation of Nigeria is an advocacy group that has been championing this and can keep doing it. Can you please talk a little about how government can mitigate outbound medical tourism? You can't mitigate it if you can't force people to stay in a health system that they don't have confidence in. And I want us to be realistic. The only way to mitigate outbound medical tourism is to fix our health system and ensure that it works. So if we have a health system where even the rich don't feel safe, they will go abroad. I don't want to overregulate, and say, oh, you can't go abroad for, no. You can't mitigate it except you fix our health system. Let me say this emphatically, that people will rather pay to be treated in Nigeria where their support system is than go to any other country if they know that the quality of care is the same. We've had cases of patients who stopped their cancer treatment, oncology treatment, because there was nobody to stay them in. They just could not stay away from their support system in other countries. Nigerians would pay to stay at home, especially with the way the foreign exchange is behaving. So if we fix our health system and make those things available, I believe that outbound medical tourism will reduce. And this has been proven by hospitals like Evercare and maybe Uracare with their new laparoscopic interventions and embolizations of fibroids. And you've seen how, even though it's quite expensive, Nigerians have stayed back rather than going abroad to do it. And they do so much. They do so many surgeries, Dr. Ahmed Minolowo and the Evercare team, right? Is there a particular data tool or software methodology that you think all clinicians should learn, given data that will be key part of the future? I think critical reasoning and Microsoft Excel, first of all, because Excel can do anything. But by the time your data becomes a lot, then of course you have to build softwares and build applications. But I always say that if you can't do it on Excel and it doesn't work on Excel, it won't work if you buy an app off the shelf or you ask someone to build it for you. But we have to become data specialists. Everybody is going to need to tell their story, and data visualization is the way forward. Why is reinsurance not part of the risk mechanism in health insurance? I don't think we've gotten to that level of market depth yet, if you ask me. Our health insurance, we haven't hacked health insurance, yet. Reinsurance may work if maybe you're talking about life insurance, so we don't even have that kind of strong depth. Now, the need for every healthcare facility in the states to have a data champion by 2023 is a good way to go. Having evidence-based data translating into decision making. I'm looking forward to this. Thank you, Kemi. Yes, please. I always say this. Everybody must. If you don't have one now, please go and appoint one now, because NIDA has plans to come for everyone, to just make sure that you're doing the right thing. Okay. There should be a linkage with National Reporting Platform, true. All right. So I think that's all the questions. Okay, how can we put healthcare on the 2023 agenda for politicians? I said it earlier, show them the money. Show them the money, that's the only way. They've always treated healthcare as a social agenda, as something we can do, and that's why we get 3.1% allocation of the budget. But if you show them the money that healthcare can actually generate, look, Nollywood is generating less than $3 billion a year. And the health system, total health expenditure is $14 billion. Nollywood is making a lot of noise and they're telling our stories. Our healthcare system is backward and we're not saying enough. We're not showing the money because we can't find where the 14 billion is. But it's really right there in the informal sector, right? And we are fragmented, so we can't put it together. But personally, I know a lot of facilities that are doing $500 million, $1 billion in revenue, and it needs to come together, right? Are we also considering the TBAs and faith-based facilities, we must, especially faith-based facilities. And speaking of faith-based facilities, I think that this is where a safe care comes in for faith-based facilities and TBAs. Maybe the safe care methodology may be a way to bring them into the fold and have some quality, because a lot of childbearing is going on and a lot of maternal mortality is going on in those facilities, and we don't even have the records. Right? Following up on outbound medical tourism, do you think that the MDCN Act that limits DRS advertising is a problem for information dissemination? I don't think the limits to advertising I think it's an innovation problem, right? I don't think it's a problem for information dissemination or information within Nigeria. I think there are ways to advertise. I think you just need to strategize and find ways to advertise, right? If you go into partnerships, there are many ways to advertise. How do small facilities key into safe care? I'm going to ask someone from PharmAccess to drop their number on this chat so that they can be called. But safe care methodology is actually one that small facilities, and I don't know how small you mean by small, but small facilities can benefit from, among all the quality, the ISCO accredited quality regulations available. So the safe care methodology is actually for functional, smaller facilities that are willing to get a quality champion, quality improvement plan, right? And are willing to grow in a stepwise fashion from maybe a level 1 to level 5, So someone from PharmAccess will put their number. If not, you can contact, yes, please call Somto. Uzo is there. So the guys are there, please, because we have to start talking about a standard for TBAs and faith-based organizations. There's massive data in them, and there's massive opportunity in all these facilities, and we have to start talking about it. If we don't bring them into the fold, we're not going to be able to look at our maternal mortality rate in the next 5 years. We already have 15% of the maternal mortality burden in the world. What that means is that 15%, not the rate, but the burden. That's very high. That's very high. If there are no more questions, I will hand over to Chinedu.
Okay, so Shola has a comment to say.
Yeah, thank you very much, Chinedu. Thank you, Fisayo, for a well thought through presentation. In fact, I'm really looking forward to receiving the presentation. Just a few comments from me. We've been, all the questions and most of the questions and most of the, solutions tends to rely heavily on government, even from your example of Thailand and how they were able to achieve universal health coverage. It's all initiated by government willingness to make that happen within their country. And I just don't know if the government of Nigeria is at that stage yet where they want to take this radical decision to make positive change happen. And even if we are here till tomorrow, I'm not sure there's any government official on this call. And of course, there have been questions about how to get government buy-in. What exactly are we doing to be able to actually make this proposal to government on the best way to achieve universal health coverage? And one other thing is about taxes in Nigeria. We always, mention, NHS in England and some other countries in the world. It's difficult for me as a Nigerian to pay tax when I'm not sure how that tax will be spent. In England, national health insurance contributions, you can see what percentage of your contribution goes to different sectors, including the NHS. But in Nigeria, I would rather pay out of pocket, knowing that I can access health instead of paying a tax to a country whereby my tax is embezzled. So we can, you know, if something radical hasn't changed in Nigerian government, we can be here till tomorrow postulating on, you know, solutions. The government needs to bear, I mean, at least provide the basics, the fundamentals, the, you know, the roadmap of how they want to, you know, how they want to get things done. And we also have a lot of round pegs in square holes, even in government institutions. And it's just difficult to make change happen. And what is the way forward? Because it looks to me like even if we're here from today to tomorrow or next week, it's difficult to actually make anything happen in terms of change. I don't know your thoughts about that. Thank you. Thank you very much for the presentation.
Thank you so much, sir. So we talked about advocacy, and I know that the HFN has made, I know Ms. Ndili is here, who is Vice President of the HFN. They have been doing a lot of advocacy, and they've made some strides, some very good strides in convincing government. They had a session, I don't know if you heard about it, just a few days ago with the Senate leader, Chairman for Health, Dr. Oloriegbe. So it's not, when we discuss here, we come up with these ideas. There are actually people in this room who we have seen in the past, like Claire Mashere, Dr. Ajayi, Pamela Ajayi, Ms. Ndili, who have taken this thing and talked to policymakers and have, I mean, for instance, the intervention funds we got for post-COVID, those were a product of advocacy. You know, there are people that have done a lot of, I don't want to sound like, oh, if we stay here till tomorrow, government cannot. There are people here who will do advocacy and they lobby the government to see it the private sector way and find a middle ground. And they have done a lot of work to where we are today. They have done a lot of work. So I think that, and I understand the tax issue. I think that's a bit beyond what we can settle here. Of course, obviously, people feel like paying tax when they can see the results. Just like I said, if the PHCs are working also, you're going to buy insurance because you know if you fall ill, there's somewhere that can catch you that you would actually use. So yeah, I understand and I agree with that. But I don't want us to throw away the advocacy that's been done. Rather intensify it and see how we can put the right issues on the table. And if we keep doing it, I think we can make some progress. Thank you very much.
Okay, thank you very much, Mr. Fisayo, for that wonderful presentation. I know we all our questions have been answered, and we are also very passionate about building the healthcare sector in Nigeria. So, okay, we are about wrapping up this session. I have here with me Mrs. Njide, PharmAccess, to give the closing remarks. Now, please, are you ready?
Yes, I am. So this has been even very informative for me as well, even though I live and I breathe this subject daily. So quite a lot has been said, and I don't want to reiterate what Fisayo has said. I think Fisayo, who's really, I would call an expert in this field right now, started with the fact that healthcare is a business. I think this is something that we need to put right in the center of the discussion, because it creates the efficiency around the structures, the system, and so on. Because if we see it as a social activity, then nobody really cares what the outcome is. People take it very lightly in terms of the work that they do. So we need to infuse some efficiency within the healthcare system by thinking around it as a business. And again, this is what has driven our collaboration with Enterprise Development Center of the Pan-Atlantic University, to the extent that we want to teach healthcare practitioners and owners the business of healthcare. So that's the first thing. The second thing, which Fisayo said, which is very important, is that government really has no business doing business in healthcare if we really consider healthcare a business. We have seen through our work even in comparison with some of the activities where government is involved and private sector is involved, we can see the stark difference in terms of how organizations are being run, how healthcare businesses, systems are being run, standard operating procedures, protocols, and so on. So I think that we need to start shifting a little bit away from government doing the actual business, but let them take their role as regulator, defining the standards and monitoring. I think that's really where we need to go to. And again, we talked about the inclusion of private sector, the role that the Healthcare Federation of Nigeria is playing. And these are some of the things that we bring up, that we need to focus now more on public-private integration, as opposed to government wants to build more healthcare facilities. We can't achieve a different result by doing the same thing that hasn't worked for so long continuously. We talked about 39,000 primary healthcare centers, of which less than 20% are functional. This is the stark reality in Nigeria. And again, this is why our healthcare indices are so bad, because those primary healthcare centers are closest in proximity, especially in the rural areas. But yet, if you set foot in there, you don't find anything that's working. You don't even find human beings. Rather, you find majority goats and overgrown lawns. So how can we create efficiency around these primary healthcare systems, either by bringing in private sector to help run it, or defining structures and systems that can support the government? Again, Fisayo talked about the huge funding gap. I don't think I saw it in your presentation, but about 79% of the healthcare budget is recurrent. Recurrent means that it goes into paying salaries, consumables, but very little goes into the actual capital infrastructure. So again, this is where we need to pay attention to. This is where we need to drive advocacy. Yes, it's very difficult to convince government, but we are making strides. We are continuing to make strides. And the avenue that we use is really to test a model. If it works, then we advocate for it to be adopted at the national level, even with the help of the World Bank or other developmental partners. We talked about this access to finance scheme, which currently we are piloting in Delta State. And there's an impact evaluation ongoing right now to show that private sector brings in efficiency. And with that efficiency, in collaboration with government run down PHCs, you can improve maternal mortality, you can increase employment, you can save government funding because they don't have to invest annually, as we see in upgrading some of these healthcare facilities. So the list goes on and on and on. There's also the talk about digital technology. First of all, I must say that Nigeria, in fact, not even just Nigeria, there's no country in the world that would achieve universal health coverage as promoted by the United Nations by 2030 without digital technology. It will be impossible. The first step for us really is, how do we ensure that everybody is seen? And what I mean seen, counted, connected, and they have access to healthcare services. If you're not seen, nobody knows that you exist, you will be left behind. That is guaranteed. So how do we ensure that we get seen? Yes, there's the NIN, the national ID that's currently ongoing. Kudos to the government for that. But there's still a lot of gaps in the system. The mobile technology is also helping for the fact that if you want a mobile phone, you need to register yourself, or at least they need some basic information from you. And we know that Nigeria has 171 million active phone lines. Yes, there could be some duplicates for those of us that carry more than one phone, but it is a start. So be seen, be counted, be connected, and then you can begin to talk about access. But then what we're seeing is that that mobile phone has the potential to aggregate funding, which is a key deterrent or obstacle for a lot of Nigerians to access healthcare. You can aggregate funding in your phone through, there's so many examples in the world where this is happening in Kenya with M-Pesa collaboration and so on and so forth. But it creates transparency, it creates efficiency. You're able to scale at a marginal cost. Again, these are some of the technologies and ideas we need to leverage on. As I put in the chat, the Lancet and Financial Times Commission, which was set up in 2019, came out with this awesome report. Luckily, I was one of the authors of that report, but the focus now is recognizing that digital is a key determinant of health. And what does that mean? That your access to digital technology can actually help you either improve your health. A lot of young people are going to the internet and searching for health information, which they normally wouldn't have access to, and so on. So how do we begin to recognize the power of data, digital transformation as a determinant of health? We are also advocating that data be considered a human right, as radical as that may seem. Africa and Nigeria has one of the highest data costs in the world, even though we are low income and one of the countries with the poorest indices. People are not able to access data in order to even get connected. So that's the second thing. The third thing is that governments, developmental partners need to begin to invest in the enablers of health, enablers of digital. When you talk about digital transformation, that's a word we threw around. The first thing I think about is the Maslow's hierarchy of needs. So in the same vein, think about the Maslow's hierarchy of digital transformation. What are the basics? Electricity, do we have it? The fiber cables, the digital literacy even. So we're advocating that government takes some of these recommendations seriously and begins to invest in the enablers of digital technology. Instead of Global Fund or Microsoft, putting funds in so many parallel programs or parallel infrastructure, can they invest or, as support to the country, invest in some of those enablers? Someone talked about data rights, data trust. Can we, data is the new oil. Yes, we're trending towards that, which is why there needs to be strong governance of that data. There needs to be data trust, data solidarity, such that we're using that data to improve the system. You cannot improve what you cannot measure, and we cannot measure if we don't have the data. So some of these things are fundamental issues that need to be addressed. Unfortunately, the private sector, when it comes to the healthcare system in terms of innovation, are way, way ahead of the regulators. So can we backtrack and see how we can build capacity of these regulators, which is why, with the HMP, we were talking about who can even sponsor for some of our legislators to attend this HMP, so that they need to understand the business of healthcare. So again, there's so many things I can talk about, but I don't, there has to be a continuation. Fisayo talked about equipment on the supply side. The world is moving away from equipment procurement, now moving more towards procurement of services rather than equipment. We spend thousands of dollars buying equipment for which we don't have human beings to operate them. We don't have the operating manual, the maintenance, and so on and so forth. Can we switch away from that, where we have the equipment manufacturers set up aside and then we pay for the services being provided? Then when we circle back to insurance, some of you may know that about 35 states in Nigeria have passed mandatory health insurance laws. When you talk about the number of people that are enrolled within those health insurance laws, is less than maybe 2 million, by state. It's difficult to keep track because the data is kind of elusive. But the key thing is that nobody will prepay for health insurance if they don't trust the system. So how do we begin to build trust in the system? And this is by improving the supply side, ensuring that the entire system works and there's transparency around the work that we are doing, supporting state governments to achieve universal health coverage. So I could go on and on, but I don't want to take up too much of our time. But the bottom line, I would say, is that, you know, there is a lot of work to be done, and it cannot be done by one party alone. It has to be collaboration at all levels. Everybody has their role to play. But at first, you have to be educated. You have to understand the system before you can even begin to change it. So having said that, I want to thank all of you for the time that you spent listening to us. I want to thank EDC for the collaboration and being at the forefront of educating our healthcare personnel and industry, because I think that is also very key. Up on the screen is a healthcare management program, which, you know, as Fisai had mentioned earlier, really teaches you about the business of healthcare. So we'll be happy to, you know, answer any questions you have, even offline. We are open to ideas, innovation, advocacy at all levels, so that we can change the narrative around our healthcare system. I also want to be treated in Nigeria if I ever fall ill. So having said that, again, thank you very much. And back to you, Chinedu.
Okay, thank you very much, Mark. Thank you so much, Mark, for that. One thing that actually stood out for me is that be seen, be counted, and be connected. That's a very great one there. Thank you very much for emphasizing that. And also to let everyone, participants, non-HMP participants, know that I'll actually be coming to the family of the healthcare management program of the Pan-Atlantic University, and then in partnership with PharmAccess. This program has proven to be an eye-opener for all those that have attended. It's apart from the fact that it builds your capacity, it also helps you understand the business part of healthcare, which is actually key, because for years, the healthcare system has only just been concentrating on the professional aspect of healthcare. But it's beyond that. To think sustainability, to think succession, you have to think about the business aspect of healthcare, and that's what the healthcare management program offers. And it also brings you into a community of health practitioners and enthusiasts that also will broaden and then open up your mind towards the benefits of running a successful and profitable healthcare system. So the next cohort is starting very soon in March. We are looking at getting more people to enroll for it. And the key thing I want us to take out of this economic outlook is not just come listening to Mr. Fisayo and then Madam Ndele. It's actually about implementing the things that you've learned, some of the key points that jumped out at you, putting them into practice, and then seeing how it works for your own establishment. Also, use this opportunity to say thank you to everyone that has attended this webinar. What we've also agreed to do is that every month we'll be coming up with seminars, webinars like this, to also help educate and also enlighten our minds on the things happening around the health space. So at this point, I would like us to just do one quick thing. Can we just turn on our mic and our videos so that we can just take a quick photograph so that to show that actually attended this event. Just turn on your video. So for just a quick photograph, it won't take more than a minute. Thank you very much. Thank you very much. Thank you very much. Yeah. So you can also see mine too, and that's me. Okay, so let's just turn on our video. I'm already taking the pictures. Yeah. Okay, great. Good to see all these lovely faces. Okay, so I'm taking the pictures already. Yeah, thank you very much. Yes, thank you very much. Yeah, So I'm done. Thank you everyone for coming, and hope to see you on the healthcare management program.
Thank you for your attendance. Have a good day.
Thank you very much.
Thank you very much.
Thank you.